Perfect. Hello, everyone. Good evening. My name is Annie Benzie, and welcome to the SSAT Complex GI Surgery Fellows Grand Rounds, our second one actually in the month of February. We have an excellent talk prepared tonight. Definitely something that we really encourage you to be involved with. Use the chat box. Let us know how you do it at your programs, because I think this topic is something that is talked about a lot, but also has a lot of variability as well. And special thanks to everyone for being here, but especially grateful to our moderator, Dr. Hussam Osman, who is the hepatopancreaticobiliary and foregut surgeon and HPB Associate Fellowship Program Director at Methodist Richardson Medical Center. He's actually one of my attendings during fellowship, so I'm honored to have him tonight. So Dr. Osman, if you wouldn't mind just giving us an overview and introducing Dr. Russo.
Very good. Thank you very much, Annie. So I think we have a very interesting topic today about using ERAS protocol for Whipple procedure and pancreatic resection. Dr. Molly Rosso from Orlando is going to present the topic. We would like to make it interactive, and I think the presentation is set in a way that we can get people engaged and see how people do things in different centers, and hopefully we can learn from each other today. Without further ado, Dr. Rosso.
Sure. Here. All right, you can all see my screen. Okay, wonderful. So hi again, I'm Molly Russo. I'm down at Advent Health in Orlando, and Dr. De La Fuente is here. He's my program director, and I will be talking about ERAS protocol, or extended recovery after surgery after the Whipple. So briefly, I will talk a little bit about pancreatic cancer and the Whipple. We won't go into too much detail about that. Explain a little bit about what ERAS is, and then go through sort of in a sequential fashion parts of the ERAS protocol with regards to the Whipple, about when you might want to implement them, and then sort of finish off with how this helps. So first, what is the Whipple? Why do we do this? Why do we put ourselves through this? Why do we put our patients through this? Well, we know that for patients who have pancreatic cancer and other tumors that are resectable, who don't have evidence of metastasis and are otherwise eligible for surgery, surgical resection is the only option for a cure for them. A chance to cut is a chance to cure. And this pancreatic cancer in and of itself is the 12th most common cancer in the world. And in fact, it's actually projected to be the second leading cause of cancer-related death by 2030. So pretty serious disease. Thankfully, these days, the quoted mortality ranges anywhere from 2 to 5%, the lower end in high volume centers, which is significantly improved from the 1980s when mortality was quoted around 15 to 20%. So we made some improvements in that area. However, the morbidity of this procedure is still pretty significant, ranging anywhere from 30 to 40%, and that hasn't really changed in the last couple of years. There are a number of complications associated with the Whipple, in addition to your standard complications that you expect, like bleeding and infection and the like, most notably pancreatic-related complications such as delayed gastric emptying or post-pancreatic hemorrhage, and the most common of all of those being the postoperative pancreatic fistula. And these complications are not insignificant. They can delay patient recovery. They can become life-threatening if they aren't treated appropriately, and they affect other measures of outcomes such as length of stay and healthcare costs. So if there's a way that we can improve upon these complications, reduce that morbidity, we want to do that. Like we would want to do for any type of surgery that we do. So what is ERAS? ERAS, or Enhanced Recovery After Surgery. I'm sure most of us have heard of this before. It's a series or a number of points or interventions that are evidence-based, and their overall goal is to reduce the physiologic and emotional stress from surgery in patients and help them to recover. The first iteration of guidelines as far as pancreatic surgery goes was published in 2012, but this was based on a pretty limited number of pancreatic specific literature, and most of that data was actually extrapolated from colorectal ERAS literature. So the second iteration was published in 2019, some improvement in the evidence-based of those guidelines, and I'll be going through that today. That's what I base my talk on. It is comprised of 27 items. I will not go through every single item. That might take a couple days, but like I said, I will go through in sort of a sequential type fashion. And I chose items that I thought were maybe the most evidence-based or most interesting to me, things that I had seen in difference or in contrast between what I'm doing now and what I did as a resident. And so that sort of guided why I chose some of these items. So we'll start off with our preoperative strategies. And the first one is preoperative carbohydrate loading, which I hadn't heard of until I started to sit down and go through this talk. So what that is, patients drink a clear solution, a carbohydrate-rich clear solution preoperatively. A lot of literature talks about drinking it at midnight the night before and then 2 to 3 hours before anesthesia start time. So within an appropriate time frame for anesthesia. And the purpose of this is, first of all, to improve the glycogen stores of the liver in order to avoid the glycogen depletion that occurs with fasting preoperatively for surgery. It also, there has been literature not around Whipple surgery or pancreatic surgery, but in other cases that it decreases thirst of patients because they're allowed to drink shortly before surgery. It increases the anxiety that they have surrounding surgery, and actually, particularly in bariatric surgery patients, can attenuate the insulin resistance that you see again with an overnight fast. So in 2014, there was a Cochrane review that looked at carb loading in patients. This was a relatively small study in regards to patient number, and unfortunately, this was not focused just on pancreatic surgery. In this one, patients got 45 grams of carbs within 4 hours of anesthesia start time, and this review compared the carb loading of patients to a placebo or a fasting group and what that had, if that had any effect on their complication rates. It did not really have an effect on complication, and it did have a small effect on the length of stay, but most notably, I think for this particular study, it showed that this was safe. These patients didn't have any adverse side effects, most notably pulmonary complications like aspiration. And so before we start to investigate or institute a change in our institution, we want to make sure that something is safe. A little bit later, there was a meta-analysis done, and this took that investigation of the carbohydrate loading a step further. And this broke down the carbohydrate loading into 2 separate groups, a low dose and a high dose group. And it also took 2 control groups, a fasting group and then a water or placebo group. This one had a decent number of participants, around 3,000. And again, it did show a small effect of length of stay on these patients with the high dose carbohydrate load versus fasting only, not versus a water or placebo. But the effect was, like I said, relatively small, less than a day. When they did a subgroup analysis, they also noted that if they just looked at major abdominal surgeries, there also was a small effect on the length of stay with the high dose carbohydrate group compared to both fasting and the placebo or the water, but again, a relatively low effect. And the problem with this study, even though it showed us a decent effect with length of stay, it didn't really do a good job of investigating the complications associated with surgery. This was not pancreatic surgery specific. It covered elective surgery from abdominal surgeries, cardiac to orthopedic surgeries. And because of the significant heterogeneity of all of these studies included in this meta-analysis, they did a lot of statistical manipulation to even attempt to get some sort of effect. So the literature here is not incredible as far as specific complication rates, but it is relatively established that it is pretty safe. And so the guidelines do recommend, or at least say that a carbohydrate load is safe. But as far as specific protocols go and pancreatic surgery specific literature is concerned, there isn't really a strong body of evidence. Moving on to another topic, which I, again, didn't really know or learn about until I actually started in fellowship here, is immunonutrition. And what immunonutrition is, it is a drinkable supplement that has certain nutrients that can promote tissue healing, decrease the inflammatory responses to stress, promote a good immune function. And that does it through four main substrates: glutamine, arginine, omega-3 fatty acids, and nucleotides. And this is important because we know that, first of all, patients who have cancer tend to be malnourished and pretty profoundly malnourished by the time they get diagnosed. And they undergo a very big surgery that has a significant impact on their immune system. And those two things can combine and lead to postoperative complications. There is some decent literature outside of the world of pancreatic surgery that shows that surgery in and of itself can cause an increase in cytokine production, particularly interleukin 6. And this hypercytokinemia actually is associated with an increased risk of postoperative infections. And in fact, patients who undergo the Whipple procedure or pancreatic surgery, at least, they have been shown to have significantly higher levels of cytokines in their blood compared to even patients who undergo gastric or colon surgery. So these patients are potentially at this higher risk of complications, including postoperative infections, with this excess production of cytokines. And if we can give them something like this immunonutrition that may be able to moderate that immune response, we may be able to improve their outcomes. So 2014, a randomized control trial came out that looked at patients who received or didn't receive immunonutrition, and they focused specifically on postoperative complications. This randomized control trial was on pancreatic surgery, specifically the pancreatic duodenectomy. It was a relatively small study. There were only 50 patients, but half of these patients received this immunonutrition 5 days prior to surgery with an equal reduction in the amount of regular food that they got. And they compared that to the control group who just had regular food prior to surgery. And they were able to demonstrate a favorable effect with regards to the oral immunonutrition. And in fact, these patients had a pretty significant reduced rate of infectious complications, almost half that than the control group, 30% versus about 60%, which is pretty decent. There wasn't a significant difference in other complications, but this study was interesting because in addition to complications, they also tested their patients' blood looking for evidence of this decreased or potential difference in cytokine production and lymphocyte production. And they did note that in patients who received the immunonutrition on post-op day 0, they did have a significant lower level of this interleukin 6 compared to the control counterpart. So in addition to this, there were 2 other randomized controlled trials that I didn't specifically include here, but they also looked at patients who received immunonutrition both pre and peri-operatively who underwent pancreatic surgery. And these 2 studies focused specifically on the serum levels of cytokines and other lymphocyte markers. And both of those showed a significantly lower level of these plasma markers and these cytokine levels in patients who received immunonutrition. And so from these 3 studies, we know that there is a physiologic effect from the immunonutrition, but how much does that level or that effect sort of bear out in actual clinical complications? We're still kind of investigating. Finally, there was a retrospective cohort study, and this one took well-nourished patients, specifically who received either immunonutrition in a similar fashion preoperatively versus who didn't. Again, looking at the rate of infectious complications, and similar to that randomized control trial, about half of them compared to the control group again showed infectious complications. So 23 versus 44%. So a pretty significant, not just statistically, but numerically difference in infectious complications. And this study, even though it wasn't as strong as the randomized control trial, did elucidate a shorter length of stay in patients who received the immunonutrition by about 4 days. But again, no real difference was shown in the mortality or morbidity or pancreatic specific complications. So currently, the guidelines actually do not recommend immunonutrition, mainly based on the evidence or the data that is out there. There's a lot of heterogeneity, like I said, in the meta-analyses and the data that exists. There are a number of randomized control trials that look specifically at immunonutrition and postoperative complications, whether that's on pancreatic surgery or otherwise. But and these trials do show really positive effect, but unfortunately, when you take out all of the studies that are funded by the industry by big immunonutrition, those positive effects tend to go away. So there's a significant amount of bias, and the studies that do exist have a low number of patients. So interesting to look at. I think it's promising as far as infection risk is concerned, but definitely more research needs to be done in that era. And then finally, for preoperative interventions, we have preoperative biliary drainage. A lot of patients that come to us with cancer of the pancreatic head have obstructive jaundice. We know that obstructive jaundice can impact a number of our organ systems and our physiologic processes. They can lead to liver injury, of course, renal failure, cardiac abnormalities. They have an increased risk of infection, namely cholangitis. And so even outside the realm of pancreatic cancer, these patients tend to need to be drained to relieve that obstruction and also try and reverse or mitigate the complications that come with obstructive jaundice. And we also know separately that jaundice does convey an increased risk of complications post-operatively. And so theoretically, we would think that if these patients underwent drainage or relief of the obstruction preoperatively, they should have a reduction in their risk of surgical complications. Unfortunately, or interestingly, that did not really come to fruition in the literature. In a pretty old Cochrane review, they look specifically at patients with who underwent pancreatic resection or the pancreatic duodenectomy who had obstructive jaundice preoperatively, and they separated these patients in a group who went directly to surgery or patients who underwent preoperative biliary drainage. And that drainage was done either endoscopically with a sphincterotomy and a drain placement, or a sphincterotomy and a stent, or they had a percutaneous transhepatic drain. Notably, there was no difference in the mortality in these two groups, and even more notable, the mortality in those two groups were significantly higher than what we would expect. They were around 13 to 15% risk of mortality in this study compared to what we would expect, which is about 2 to 5%. Why that increase in mortality, unclear. Could it be because these patients had such a severe level of hyperbilirubinemia prior to surgery? Maybe, maybe not, particularly because the patients who were drained, presumably their bilirubin had been decreased with the presence of the drain. So interesting that mortality was not affected, and notably also length of stay was not affected. On the other hand, I would think even more importantly, actually, the patients who underwent preoperative drainage actually had higher morbidity than the patients who went directly to surgery. This procedure increased their risk of sepsis and infection, and they also increased their risk of postoperative complications, which is significant. You don't want to do something to your patients to cause them more harm. And then also included in the guidelines, kind of separate, were a number of meta-analyses that again sort of just reiterated or supported the results from that previous study, was that these biliary drainage procedures, in the context of having them done prior to pancreatic duodenectomy, increased all the patients' risk of infection, their length of stay. They had a number of complications from the drainage procedures themselves, whether that was perforation or bleeding. And not to mention the percutaneous drainage procedure actually caused patients more discomfort. There were at least 2 studies that specifically asked patients if they had any pain, if they had more pain, or a moderate amount of pain due to these percutaneous drainage tubes, and it did cause them pain. So in the context of all this, with no change in mortality and a significant increased risk of complications, drainage procedures should not be routinely done prior to undergoing pancreatic duodenectomies. And that was the official guidelines recommendation as well. So before I speed on ahead,
if you can just make a stop here and kind of see what other sites do, especially when it comes to the preoperative biliary drainage. When I started my fellowship over a decade ago, this is when preoperative biliary drainage was a no-no for resectable pancreatic head adenocarcinoma. But as you mentioned, nowadays we think that when the bilirubin above 15 or it gets to 20, we get a little bit nervous. And I think subjectively we see that in the quality of tissue and even the need or their coagulopathy status. So preoperative biliary drainage is used a little bit more, I think, across the nation for bilirubin greater than 15, and definitely for all patients who need no adjuvant treatment. And I would love to hear the input from other side, but I can tell you that one of my concern with preoperative biliary drainage and ERCP preoperatively which is a low risk, but in my mind it will change completely the trajectory of the treatment is development of post-ERCP pancreatitis. On the other hand, PTC, yes, pain is an issue, but what worries me really the volume and electrolyte loss, and I find it very difficult for patients with PTC to actually be able to go through their neoadjuvant treatment because of the volume management issue and sometimes the need for admission for AKI. But I would love to hear the input from other sides. I have a list of sites who historically joined this meeting. Do you have anybody from University of Florida Health in Jacksonville? And if no, I would like to hear the input from any willing participant. Do you have anybody from Carolinas Medical Center? University of Maryland, maybe? Well, I'm going to start calling names then. I see one of our fellow here, Ryan from Banner Gateway Medical Center. Either you or your faculty. You guys have any comment about that?
We typically don't perform pancreatic duodenectomy at our institution, so I guess I don't have too much additional to offer, but it was the same in residency where we use a cutoff of between 12 and 15 for bilirubin for drainage.
Any site that perform Whipple procedure? Please feel free to share wisdom with us.
I think it's important to realize the difference between the data and reality, right? And reality is that most patients come to us from GI. And by the time they get into my office, they already have a stent placed in the biliary system. And I agree with you, there are significant potential complications from that, but that's the reality. I can't even remember the last time we did a Whipple without a stent, and I do between 40 to 50 a year. But it is what it is. We have to just treat the patients with antibiotics if you think that's the way to do it. I culture all the vials that had stents placed preoperatively. But the reality is that most patients do get a stent even when we don't need one.
I agree, and I think we had to go, especially kind of early. I remember during my fellowship time and after fellowship, we had to go kind of educating the gastroenterologists because back then we really believed that preoperative drainage was more dangerous than what we think now. So we had to go in an education kind of round. But I agree with you. I would say that in our what we see,
Sure.
I
Yeah.
just wanted to jump in
Mhm.
and also say that, we looked at biopsies on these patients that had obstructive jaundice. I put this in the chat. And, fibrosis in the liver progresses actually fairly quickly after obstruction. And I think most of the time we're operating on patients with some underlying liver disease. The other thing that's sort of interesting, and I think our data would suggest that if they're not stented preoperatively, we tend to lose more blood in those cases for whatever reason. The other thing that's really interesting, and I'm actually surprised to hear this from you, Dr. De La Fuente, most places are doing neoadjuvant chemotherapy, right, in these patients. We are not for resectable lesions. And so we tend to take them straight to the operating room if they are clearly resectable. And we follow adjuvant chemotherapy. I think that's changing the paradigm. And the last thing to say is, we have a presentation at the HPBA looking at how pancreatitis does delay treatment. And in fact, first course of treatment is delayed in patients that had post-ERCP pancreatitis. And it was interesting because in that group of patients, it looks like it's a reasonable cohort because indomethacin, when used, did decrease the risk of post-ERCP pancreatitis. So I think it's a valid set, if that makes sense.
That does make sense. I think post ERCP pancreatitis. I think pancreatitis in general with Whipple is kind of under diagnosed condition. We know post ERCP pancreatitis. Later, I would love to see if we can get to actually post Whipple pancreatitis. I think one of kind of very underdiagnosed condition and problem. But Dr. Rosa, you want to go ahead and continue?
Sure. Yep. So we'll move on to intraoperative strategies now. Very briefly, point of contention for me is avoiding hypothermia in the operating room. I don't know about everyone else, but I hate being hot. And so it's a constant battle about keeping your patient nice and warm in the operating room and keeping me, at least, nice and cool. But this is important because we know that the negative effects of hypothermia on our patients, including cardiac, wound infections, and other generalized morbidity. And so keeping them at an appropriate temperature is important. So how do we do that in a passive manner? And can we impact this even before we get to the operating room? There was a randomized control trial that looked at pre-warming versus a control in patients undergoing just general elective surgery, not pancreatic specific surgery. And these patients were either given or subjected to 30 minutes of forced hot air prior to the induction of anesthesia, or they were provided warm blankets after they had asked for them. And their primary endpoint was a magnitude of hypothermia experience. And unsurprisingly, that was lower in the pre-warmed group. Now, what does that mean clinically? Kind of unclear from this specific randomized control trial. There wasn't a difference, most notably in surgical site infections, but I think in general it's accepted, and there is a lot of other data out there that recommends keeping your patients at a normal thermic during procedures, particularly with regards to infections. And the guidelines do recommend, unsurprisingly, maintaining a core temperature of 36 degrees Celsius for these patients. And this in particular, especially the forced hot air group, and where I trained, there was a push. It started with our breast before surgery, and they had forced hot air circulated through that gown before cover every single patient that underwent surgery. And so right before I left, every patient who came in for surgery, regardless of how big or how small, got this gown, this bear hugger gown, and received this active or this forced hot air warming prior to surgery. So moving on, something that we actually kind of focus on a lot at my program now is fluid balance. There is a suspicion or concern that volume overload can negatively impact the rates of pancreatic fistula formation, which this is the most common complication after pancreaticoduodenectomy. So anything we could do to decrease that risk, we would want to. That volume overload, it's thought that it impacts, or the fluid shifts increase edema in the bowel wall, which then leads to an inflammatory reaction and then leads to the potential breakdown of the pancreaticojejunostomy. But on the other side of things, we don't want our patients to be hypovolemic. We know the negative effects of that, including renal function, cardiac dysfunction. And so how do we achieve this euvolemic state of patients who are undergoing massive fluid shifts? They're undergoing incredibly long procedures. They're receiving medications in the operating room, which can affect their hemodynamic and make things even and inappropriate for them. There were a number of observational studies that came out that actually did not show a difference in outcomes in regards to a liberal or a more restrictive fluid protocol in patients who underwent pancreatic duodenectomies or other pancreatic surgeries. So these observational studies did not, in fact, actually show that there was an increase or decreased rate of pancreatic fistula formation with more restricted fluids. However, the problem with a lot of these studies is that, again, there's a lot of heterogeneity. There was a lot of differences in the triggers for fluid resuscitation. There was a lot of differences in or inconsistencies in how much fluids were given at any point in time if patients were bolused. And there were a lot of different definitions for fluids. Was it crystalloid? Was it colloid? Was it blood? And even in these studies, some of them were done in the context of an ERAS protocol, and some of them were not. So we're kind of starting off with some general knowledge and ideas of what needs to be done as far as fluid balance goes, but no real protocol or way to achieve that. So then, thankfully, 2017, there was a randomized control trial that actually looked at a goal-directed therapy protocol to decide how much fluid and when to give these patients fluid who are undergoing an open pancreaticoduodenectomy. And the way that they did that is they hooked up every patient. They got a central line and an arterial line, and the patients were connected to an EV1000 or a Vigileo or some type of monitoring device that monitored their cardiac output and their cardiac index and their stroke volume variance. And this group used the stroke volume variance at greater than 20% as the trigger point to administer a fluid bolus, particularly if the patient was hypotensive. If that stroke volume variance was normal or was not above 20%, then other things like patients' MAPS drove other interventions, such as vasoactive medications. So their hemodynamics were monitored and controlled in an appropriate fashion in the operating room, but depending on what their stroke volume variance was or their MAP, they got fluids or vasoactive medications. So based off of that algorithm, they had a group that underwent this goal-directed therapy, and then they had their control group. And their primary endpoint for this study was length of stay. And they were able to show that the goal-directed therapy group had a shorter length of stay compared to the control by about 4 days, which is pretty decent clinically, I think. Secondary endpoints were the amount of fluids that they got. So intraoperatively, patients in the goal-directed therapy group got significantly less crystalloid compared to the control group, about 2 liters versus 4 liters. So not an insignificant amount of crystalloids. And that pattern sort of came down the line as far as other fluids were concerned. Their total fluid volume was significantly different. Again, about a difference of 2 liters between each group. But there was no difference in colloid administration or blood administration. So it wasn't like the goal-directed group was getting way fewer crystalloids, but we were compensating with blood or albumin, for example. So their total fluids were significantly less than the not goal-directed group. And interestingly, particularly for me, when looking at this study, was that their urine output between the groups was basically the same, a little bit over half of a liter between these two groups. And to me, when I think about fluid restriction, certainly an AKI or renal dysfunction is something at the top of my list of concerns, particularly in these big open cases. The length of time for surgery in this study was about 8 hours per group. So this is a very long open case with a lot of insensible losses, and it seems like these patients may not be getting a lot of fluids, but at least as far as urine output goes as an endpoint of resuscitation, there wasn't a difference between these two groups. Minus just reduction of fluid administration, This study also showed that there were complications if you were not part of the goal-directed therapy group, namely being an increase or a higher likelihood of receiving a blood transfusion. Your 35% of patients received a blood transfusion in the not goal-directed therapy group compared to no patient in the goal-directed therapy group. How is that explained? I don't know if 2 liters of crystalloid is enough to explain a blood transfusion in someone who otherwise had a relatively normal hemoglobin perioperatively, but I think just the risk of blood transfusion in and of itself is notable, especially because we know that patients who undergo pancreatic duodenectomies for pancreatic cancer, if they receive a blood transfusion, they have poor survival compared to those who don't. So that I think is significant. Otherwise, there wasn't a lot of other differences, importantly in pulmonary congestion or AKI between these two groups. And there also wasn't a difference in pancreatic fistula formation. Each group had 1 patient each that developed a pancreatic fistula. So that kind of goes against the concern at the start of this, that volume overload can lead to pancreatic fistulas, but I think just the decrease in fluid administration and importantly, the increased risk of blood transfusion is a pretty notable complication that came from this study. So another study, a retrospective cohort study, again, all open pancreatic duodenectomies, wanted to investigate whether there was a threshold for a volume of fluid that could change outcomes for patients. So they kind of took a backwards glance. They looked at patients who underwent an open Whipple and divided them into patients who had complications or no complications. And patients who had complications did receive higher volumes of fluids compared to those who didn't. And there was a weak correlation between that volume and the calculated comprehensive complication index for these patients. They took each patient and plotted them on this scatter plot at the intersection of their complication index and the total fluids. And there was a linear correlation between fluids and complications. It was a weak correlation, but it did exist. And so extrapolating from that weak correlation, they were able to identify a threshold of about 4.5 liters as an independent predictor of complications. And in fact, when they went and did logistic regression analyses in the patients who received under that threshold, they did have a lower complication rate, a lower median complication index, fewer complications from pulmonary problems, and a shorter length of stay, but otherwise no other major complications, differences in major complications, again, notably in the pancreatic fistula. So in general, again, the guidelines recommend avoiding fluid overload, maintaining your patients at a euvolemic state, but importantly, to do this, there should be some sort of guidance with some sort of algorithm. I think the retrospective study that identified that threshold of 4.5 liters is interesting, but outside the context of an algorithm should maybe just be something that we identify as, hey, if we're reaching this fluid, be concerned about complications. Do we need to be a little more hypervigilant? Do we need to back off? Are we giving fluids appropriately? And things like that. And finally,
if we can just make a pause here just very quickly, because goal-directed fluid therapy is a consistent recommendation for ERAS across multiple surgery, not just for Whipple, and something that require buy-in from anesthesia and in addition to pre-op carb loading. So I would love to hear your experience first at your institution with the engagement of anesthesia and how do they do their goal-directed fluid therapy, and I would like to hear from other sites as well.
Sure. So for us, like you said, it can be a challenge with our anesthesia colleagues. A lot of them have been here a while and they know Dr. De La Fuente very well. And we have sort of a goal of units per hour, which has been shown in other literature. So our approach mainly is to kind of just discuss that with them before the case starts and say, hey, this is about what we're looking for. We like to give our patients, this amount of mils per kg per hour. And if you are going to stray from that significantly, or you find that you're bolusing, we hope that they communicate with us and they cross that blue barrier. Does that always happen? No, of course not. It depends on how good of a job I did talking to anesthesia beforehand and how good they are at communicating. But that's kind of our approach.
Dr. Giroggio, you had one of your students present a really nice paper this weekend at the North Texas American College Surgery chapter. So do you want to give us
Yeah. So this is really exciting, actually. We were able to show Dr. Russo that high volume anesthesiologists impacted on outcome with pancreatic duodenectomy, which is no surprise, right? Because we all want dedicated people,
Sure.
and certainly we think transplant has dedicated transplant anesthesiologists, etc. So it was really interesting. It was interesting also because our high volume anesthesiologists tended to use more colloid than crystalloid than our low volume, which kind of would fit with ERAS. The other thing that I think was interesting that we haven't published is that early in our experience with ERAS, we found actually we were too restrictive and we had a little bit of renal injury in some of these patients. Kind of would love to see if anyone else, Dr. Day, I think you're on, have you had any experience with that, with kind of too restrictive fluid management?
Absolutely. I think you can definitely go too far in the too restrictive side of things. For me, I do a lot of liver work as well. And what's been helpful for striking that balance is I have anesthesiologists that are very used to my like harking on them for low CVP during liver resections. And it really transfers in their management over to Whipple. And I think we strike a nice balance. And I wouldn't be surprised if some of it is similar pathophysiology in the liver. You have higher CVP, you give more fluid, you get more bleeding, therefore you give more fluids, you get into this cycle. And I think the same thing happens in Whipple because you're talking about the same circulation just transmitted through the portal vein. And uh, so I do think it's important to be proactive, not get ahead too early, but also not be behind like you're talking about. I have definitely dealt with the renal injuries.
Yeah, no, I think that that's a really good point. I mean, the other thing is also time under anesthesia, right? And so one of the things that we've also found is that we haven't published this as yet, but we're working on the sort of a little bit more of a analysis of this data. But it looks like the longer time you spend under anesthesia, the higher risk of pancreatic fistula, actually, in our experience. And we tend to be fairly, I guess, expedient, Dr. Osman and Dr. Benzi, with our Whipples, and that we have kind of a really good process as far as team, techs and things in the room that you need for the procedure, etc. So it helps with time efficiency. But I really think time under anesthesia impacts on fluid management too, obviously.
I think
agree?
it definitely does as well. And it's an interesting point because the longer your operation is, the more difficult your operation was. So it's probably predisposed to complications and you're getting more fluid because you're there longer.
Dr. Rosso, you want to continue?
Sure. So moving on to minimally invasive surgery techniques. So the first laparoscopic pancreatic duodenectomy was performed in 1994, and the first robotic was reported in 2001. But widespread adoption of these minimally invasive techniques have been relatively slow, and part of that has to do with the reconstructive aspects of the pancreatic duodenectomy. And the challenges with the ergonomics that the surgeon experiences and the difficulty with particularly laparoscopic surgery, the angles that we have to work at. So not this has not become incredibly widespread, but minimally invasive approaches have shown benefits in other surgeries. So at the time that the guidelines were put out, they had recommended only high volume, super experienced surgeons be performing laparoscopic pancreatic duodenectomies, and they barely commented on the performance of robotic pancreatic duodenectomies because they didn't feel at that time that there was really enough literature. And I don't think, not to get ahead, but I don't think that that has really changed. The one study that was included in the guidelines that they had quoted was a retrospective review that looked at outcomes based on case volume, which I think is pretty important, as well as surgical techniques, so either laparoscopic or open. And so this group divided these patients or these institutions into quartiles based on the volume, and then they compared laparoscopic versus open outcomes based on that quartile, and then also for the entire cohort. And ultimately, they were really only able to show a difference in outcomes in the highest volume centers. They did have a shorter length of stay for laparoscopic surgery in these high volume centers compared to open, with the difference of about a day. And laparoscopic cases also had a lower readmission rate, but as far as other outcomes, 30 or 90-day mortality or positive resection margins, there was no statistically significant difference in any quartile between laparoscopic or open surgery. And really, I think the crux of this paper in particular, really more than examining a laparoscopic or open method of performing the Whipple, was the majority of patients who had better outcomes. The statistical significance came from high volume centers, whether that was mortality, resection margins, or other complications. If you had your surgery done in a high volume center, you were more likely to have a better outcome. And I think we all kind of understand that intuitively now as well. There was a randomized control trial really recently that came out of China, just in 2024. And this one specifically looked at robotic surgery versus open pancreaticoduodenectomies. And this one I included because notably, not only was it a randomized control trial, but the authors wanted to note that the surgeons who performed these surgeries were experienced, and they had surpassed what they considered the learning curve, if you will, of performing these procedures, both robotically and open. So that learning curve bias was sort of taken out of this. This was a decent sized study, almost 200 patients, and their length of stay was their primary outcome. And unsurprisingly, they were able to demonstrate a shorter length of stay in patients who underwent the robotic pancreaticoduodenectomy by about 2 days. But otherwise, there wasn't a difference in mortality, complications, or readmission rate. This study did not look at cost or operative time, though, which is, I know, kind of a bone of contention in the anti-robot group. So in 2020, there was a meta-analysis that did look, again, at robotic pancreaticoduodenectomies compared to open. There was a number of randomized control trials included in this meta-analysis, and almost 13,000 patients included, and they were able to show a positive effect in the robotic group. These patients had decently significant less blood loss compared to the open group, about 350 milliliters of estimated blood loss versus around 600 milliliters of blood loss. How they were measuring that blood loss and how you estimate it, is there a difference when you're just visually robotic versus open? It's unclear, but so that's a possible point of difficulty or lacking in that study. But they did show a positive effect with the robotic group, and they also showed a pretty significant decreased rate of surgical site infection in the robotic group as well, by almost half, 12% versus about 24% rate of infections. On the other hand, unsurprisingly to some, the robotic group did have a longer operative time of almost an hour and a half longer than the open group. And the robotic group had more expensive surgeries. Only a few number of studies from this meta-analysis actually commented on the cost of the surgery, but one in particular noted a cost increase of about $18,000 in the robotic group versus the open. So no other differences in mortality or other complications, particularly pancreatic specific complications, and the number of lymph nodes that they harvested and the surgical margins, there was no difference there. But maybe a little promising as far as complications go. And then finally, there was one more retrospective cohort study that, interestingly, this again was a robotic or versus open evaluation, and this one was done in the context of an ERAS protocol. So these patients were kind of already set up with an attempt to promote success, and part of that study also kind of looked at the differences in what their institution did as far as the ERAS protocol was concerned and what the published data was. So that was sort of an interesting take. In comparison to the meta-analysis in 2020, the robotic group actually had a shorter operative time, but not by that much, maybe about 30 minutes. Again, their length of stay was less, their risk of blood loss was less, and they actually showed a smaller incidence of postoperative pancreatic fistula in patients who underwent robotic surgery as opposed to open. So a little bit more promising as far as pancreatic specific complications are concerned. But nonetheless, I think overall the guideline recommendations still stand. If you're going to do a minimally invasive procedure, it should be done at a high volume center by someone who's experienced. There's a lot of data that could still be evaluated, whether these benefits that an MIS procedure conveys versus the complications or the downsides, namely cost and operative time. And there's not a lot of long-term data as far as the oncological safety of these procedures. We use harvesting of lymph nodes and margin status as surrogates for oncologic outcomes, but we don't have like long-term oncologic survival to note. So I think that would be something that is pertinent if we're going to make major changes in our surgical technique. So take a little pause
I know
here.
we're short in time, but I think this minimal invasive Whipple versus open Whipple that deserve at least a minute or two kind of to discuss. So any center here that they do minimal invasive Whipple and their experience of the outcome of minimal invasive Whipple versus open Whipple, please feel free to give us your share experience with us. Dr. De La Fonte, do you want to start? We can hear you. You're not shown as mute, but we're unable to hear you.
Can you hear me now?
Yes, what now? Yes, I can hear you.
I personally don't do any minimally invasive Whipples. I went through the process of when I was in training, 15 years ago, we tried those at Duke and then at Moffitt, and my experience was not great, probably because they were the first cases. Trailblazer actually look at this data, and the time that takes for someone to get from the surgery day to adjuvant chemotherapy is exactly the same whether you have an open or a minimally invasive Whipple. And I think that should be what most people should be looking at, not length of stay. I mean, obviously that's important, but the question is, when someone completely recover from a Whipple in order to be able to get chemotherapy? The reality is that the morbidity of the operation is related to the gastric emptying and the pancreatic fistula, not the number of wounds. But certainly for some people that maybe have tumors away from the portal vein or did not get any chemotherapy and don't have a lot of pancreatitis, maybe there might be a role, but I don't do them. Ryan has done a few, I think, and maybe Ryan, you can give your take on the first Whipples done robotically here at Advent Health.
Yeah, it's kind of like you said, length of stay is really the wrong metric for robotic Whipples. I think you showed the Chinese RCT, and decreasing length of stay from 13 days to 11 days is not a win to me because that's longer
2
than what
days.
anyone would consider reasonable for either cohort
Sure.
in the United States, really.
Mhm.
What determines how long people stay after a Whipple is whether they leak or not. And I think there's good risk stratification pathways for that from the MD Anderson group, the pancreatic risk fistula scoring system, and that can help you get people out quicker, and that deals with length of stay. But the interesting thing to me is the postoperative pancreatic fistula rate is the same between robotic and open, but there was the international minimally invasive pancreatic group that recently looked at, well, what happens when patients leak, and robotic leaks tend to be worse than open leaks when they do happen. So that's something you've got to consider in the patients that you're trying to allocate towards your minimally invasive side of things.
Mhm. Well, and I think too that really just highlights the cherry picking that we can do when we have these studies, right? Is they pick length of stay because particularly some of the earlier studies, they can power them for length of stay and they can get good power, and then they look at the complications as secondary outcomes. But if they powered them for complications and things, their study might not be powered appropriately. They need more patients and the like, and particularly a lot of these studies hosted by Da Vinci and other companies want to good outcomes. And so they're going to put out papers that are not inaccurate, but may skew people's thoughts if they just look at the bottom line and say, oh, this is a really great thing.
Dr. Rosen, I
agree
with everything that was said, and we can critique those paper, but 100% agree with everything that was said, especially that the fact that when they develop bleed, they seem to do worse. But we have 3 minutes, so if you want to go ahead and finish your presentation. So
I've been babbling.
Right.
Sure.
Can we just move to the efficacy slides? Because I think that's really important.
Yeah,
as much as
absolutely.
I love tubes, as everyone knows, but I think the efficacy is really driving this home too.
Yeah. Don't put NG tubes in your patients unless they need it. That's really it. So, does ERAS help? You know, we have all this literature that says there are some good things and some bad things, and this is maybe how we should be treating our patients postoperatively. And certainly, you know, for me, I'm not just learning and improving on how to do these procedures, but soon I need to get these patients set up before they have surgery and take care of them afterwards. And if I'm going to follow a protocol, I need to know that it's going to work. And in other literature for other cases for ERAS, we know that if you can achieve a decent compliance for that protocol, you can actually impact outcomes. There was a randomized controlled trial in 2019 that specifically looked at patients who underwent an open pancreaticoduodenectomy. They were all conventional Whipples. And specifically, this was a non-inferiority study. And so they looked at these patients who underwent either the ERAS protocol or what had been kind of like their standard protocol previously in place. And they also examined what not just outcomes, but also how differently this protocol, their standard protocol, varied from the current ERAS protocol. And there were some significant differences, but most importantly, the using ERAS did not show, or it showed non-inferiority compared to the standardized protocol that they had previously in place, or the standard protocol that they had previously in place, notably in regards to pancreatic-specific complications and length of stay as well. But importantly, from this study, the patients who were under the ERAS arm actually statistically had a higher class, a higher ASA class. And so these patients were not necessarily set up for success compared to the control group, and yet that non-inferiority was demonstrated. And then finally, there was a systematic review just published last year that also looked at incidence of complications as a primary endpoint with regards to an ERAS protocol and pancreatic surgery. And again, that ERAS protocol was associated with fewer lower grade complications and fewer pancreatic specific complications, specifically the fistula and the delayed gastric emptying, and kind of going back to what we were saying before, a shorter time to adjuvant chemotherapy. I'll skip ahead to here. Oh, it just froze. There we go. So what does all of this mean? And thank you for listening to me. Certainly using some sort of protocol can improve outcomes, and we don't want to compromise safety. And for the most part, that has been shown. But implementation of certain protocols can be challenging. We were kind of talking about it before we started that, standardization, not every patient is going to fall under a perfect category that requires or should undergo every single intervention that we have outlined in that ERAS. And sometimes what we like to do and what is shown in the literature, it doesn't happen in real life. And so widespread implementation can be a challenge, certainly. And again, I think we touched on the fact that there's still a lot of more research to be had to provide this evidence to support or oppose some of the targets on this protocol, notably, like I was saying, in long-term outcomes and long-term oncologic survival, and how each element plays into itself. If we were able to do one thing, but that negatively impacts another item on that ERAS protocol, is this going to affect long-term outcomes as well? So that's all. Thank you.
Dr. Benzi?
Dr. Osman, thank you so much for being our moderator this evening. Dr. Russo, excellent presentation. Sorry if you have your crying baby in the background right now. I really appreciate all of you for being here tonight. And again, for this great topic, like I think we've shown there's a lot of variability, and it's something that it's really important to continue that discussion about as well. Our next session will be here, same time, same place, about the use of impedance pH testing in foregut surgery. So stay tuned for that coming up in March. And if everyone wouldn't mind just smiling for a second, and I'll take
Can
our
we
picture.
unshare Dr. Benzie so that we can have